I'm going to talk about mostly the Intern Health Study, a little bit about Compass, but I'll focus on the Intern Health Study because I'm going to try to frame the mobile technology work we do in the context of prevention and why I and we think that there's real potential both for the field in emphasizing prevention of depression and other mental health problems, and particularly the role of mobile technology there. And uh, happy to have a discussion about that or anything else, and happy to answer questions throughout the talk or at the end. And particularly, there's a few people here who've helped put together this work. So if you guys have thoughts, please weigh in. Um, so our at the Depression Center, we last year started a new initiative, this digital health behavior initiative. Um, and with gifts and investment from the university, we're devoting something like $30 million to this over the next 10 years, to try to advance prevention, targeting modifiable factors to help prevent depression. And really, I think we as Michigan can really take the lead and do groundbreaking work is doing that with digital technologies and mobile technologies. And so I would love for you guys to check out what we have there, and there'll be funding opportunities. There are funding opportunities, ongoing projects on different aspects, from um, starting new studies to policy, educational events, and but it's all evolving. And if you have ideas and thoughts, please reach out to me or others in the center. Um, so to sort of frame a little bit about why we're focusing on prevention, and in this talk, why I'm focusing on prevention, depression is incredibly prevalent, probably affecting, something like 400 million people around the world at any given time, across uh, every country, across all different age groups. Um, and it has profound effects both for individuals suffering with depression, their families, their workplaces. Um, and so it's a critical public health target and priority. Um, as a field, as we invest a good amount, not enough, but a good amount in trying to reduce the burden of depression, uh, somewhere around 20, $25 billion a year into depression, mental health more broadly. The vast majority of that funding goes into treatment to try to understand the sort of neurobiology behind depression and find new targets for um, medications and treatment, to encouraging the use of treatment, reducing stigma, increasing capacity of our treatment system, um, and evaluating new treatments that come about. And this has probably been the focus for the last 40 years, and there's been real progress because of this investment. Um, we know a lot, especially in neuroscience. There's been major advances, genomics, for decades we couldn't identify a single gene involved in depression, and now there's probably 700 or so variants that are definitively associated with depression and similar across psychiatric disorders. Last year they mapped the every neuron in the Drosophila, and understanding sort of what they do and how they connect to each other, which is an incredible accomplishment. Um, Many new tools have been developed, so there's been real progress at the neuroscience level. There's also been progress in treatment. Um, the proportion of people who are depressed or anxious who get treatment has gone up dramatically, doubled in the last 15 years, and now about 11-12% of all US adults are on an antidepressant, which is again much larger than it was before. But at a higher level, we haven't had much success with this investment. The treatments that we're using are in terms of efficacy pretty similar to what they were 30 years ago, both for psychological treatments like cognitive therapy and mindfulness and medications, the SSRIs and first-line antidepressants are all ones developed or cousins of ones developed in the 80s and 90s, and even there's newer excitement about some drugs, but they tend to be older drugs that were around and we're trying to refine, like psilocybin and ketamine. Um, and we haven't made any progress at all in sort of reducing the burden of depression. The rates of depression continue to increase and again are about 15% higher in the last 15 years, particularly among adolescents, um, despite increased treatment and increased understanding of biology. So this suggests a different approach could be warranted. In other diseases, as a field, we have made progress. So, at any given age, you're much less likely to die from a heart attack, a stroke, than you were 40 years ago. Similarly, you're less likely to die of cancer than you were 30, 40 years ago. And for both cardiovascular disease and cancer, even though there are new treatments and new effective treatments, the vast majority of the improvement has been through prevention. Um, Cancer, which is what I have up here, 80% of the progress in death reduction from in cancer is due to prevention, and usually targeting modifiable factors. So a lot of the progress in cancer is through reduced smoking, skin protection, things like that. And even though there's been huge advances in immunotherapies and CAR T and things, those advances are dwarfed by the advances in prevention. Um, in depression and mental health, we haven't invested nearly as much into prevention, only 5, 7% of our overall investment. But I think we're at a point where this kind of investment would be warranted. Um, I think Hughes on the call, and I just wanted to point out a new paper from her and Leah Richmond Ricard in psychology. I think making an even stronger case for prevention. This is using data from the Michigan Genomics Initiative and using Mendelian randomization, a way to get at causal relationships. But uh, to sort of summarize, we find that the genomic predisposition for depression is associated with the majority of other diseases. So depression and a lot of other diseases are correlated. And what this finds is depression tends to cause most other diseases, whereas the relationship the other way is not nearly as strong. Most other diseases, either we don't have power or don't cause depression. Um, but this implies that if we can successfully prevent depression in cases, that would also prevent progression to a lot of other diseases and have even benefits beyond just mental health. So we've been classifying sort of the factors to target for prevention into three major categories. And I won't talk about sort of the distal societal ones on the right, things like childhood maltreatment, poverty. They're important to do. We're not really getting at them in our studies. I'll talk mostly about the first two factors that are important for depression that we can target that are specific to individual populations. I'll talk briefly about that, and then most of the time talking about lifestyle factors and as potential targets. Um, I'll start with the Intern Health Study. So this is a long-standing study that we're enrolling our 20th cohort right now, about to enroll our 30,000 subjects. Um, each year in March, a new group of graduating medical students match into residency programs. So the first year of being a professional doctor in March, during this time of year, April, May, June, we enroll a new cohort, assess them through a pretty long baseline questionnaire, importantly for this talk, either provide them with a wearable, a Fitbit or an Apple Watch, or increasingly use the data from the wearable they already have, and enroll them in a app through My Data Helps to get to pull in information and get daily mood, and then in about 6 weeks they'll all start their clinical duties in the hospital as interns, and dealing with the stress of that, and then we'll follow them through that period with mobile technology, mood scores, and surveys. So the crux of the study is that we're following people from a low stress period to high stress period. We measure depressive symptoms through the PHQ-9, and the proportion who meet criteria for depression goes up from about 4% before the year to 25% or so during the year. And in a sort of prevention context, this provides a really nice situation where we have an opportunity for to understand what factors predict depression, because we know that they're going from low stress to high stress, and to try out prevention approaches. Um, so over the 20 years, we have found a whole bunch of factors that associate with greater depression or depressive symptoms during internship. And this is just a partial list. The ones in red and green are ones that are potentially modifiable, either individual things or workplace or institution level things that are potentially modifiable, and I'll focus on those there um, as potential targets for prevention. Um, just to highlight one that as an example of a population specific factor that we could target with prevention. Um, uh, this work, it was an emulated trial showing that if you assign people to different increasing levels of work hours, that associated strongly with depressive symptoms, which is not unexpected, but the strength of the association, people working 85, 90 hours a week, had about a depressive symptom increase about 2.5 fold compared to people working 45, 50 hours a week. And the fact that it seemed a linear trend was of interest. And this implies that if you could reduce work hours, depression would or should come down. And over the course of the study, that's essentially what we found. Um, this is data now extended to 2024. And over the you could see over the course of the 19 years or so, depressive symptoms are down about 25-30%, and the increase in developing depression during internship is down about the same amount. And there seem to be a few factors correlated, but the most important is work hours. Work hours have gone down about 10 hours a week over the course of that 20 years, and that seems to be driving the decrease in depression. So this sort of highlights an example of targeting a modifiable factor specific to a population and having that result in an improvement in depression. Um, I'll focus now on, for the rest of the talk, on the center category of the lifestyle factors as a modifiable factor for depression. And a lot of those, what are considered lifestyle factors in sort of the field of lifestyle psychiatry, some of them listed here, also change pretty substantially with internship, that you lose social support, sleep duration goes down, sleep gets more inconsistent, and other things, and those things correlate with depression. So again, these can make for good targets for prevention and things we can modify. Um, One of the problems of why I think the field hasn't made that much progress in lifestyle psychiatry is traditionally, up until mobile technology times, all these things were measured subjectively. We asked people how they were sleeping, or how much they were exercising, how much they were spending time with other people. Um, uh, One of the, I think, huge advance of mobile technology for our field is we can measure a lot of those things objectively now. So, as I mentioned in the study, every subject has a wearable, and we also ask them each day to enter their mood um, and get a DNA sample from them. So just with the daily mood score, we can gain some important insights, and one of them I'll just highlight that work Adam led. Uh, we find well, Daniel Kahneman's a economist who won a Nobel Prize for multiple things, but one is sort of mental shortcuts or heuristics people have. And he found that when thinking about emotional events, people don't really integrate sort of across the whole event and remembering how good it was or how positive or negative it was, but have what he calls this peak end bias. So when you go on vacation and then tell someone about the vacation afterwards, you're not really recalling the whole 2 weeks. You're recalling the best part of the vacation and then the last day or the way it ended. And we find the same thing with depressive symptoms. The PHQ-9, which asks about the last 2 weeks, your score there is not really an average of your last 2 weeks of mood, but it's more strongly correlated with your worst mood over that 2 weeks and the mood today, the end mood. So that heuristic seems to hold, and maybe this has implications of how we assess people between patients between visits or during conversations, but as an example of what we can do with just getting daily mood on everyone every day. Um, uh, but more centrally, with the phones and wearable devices, we gather a lot of constructs now that are um, capturing things that are important or we think are important for well-being and mental health through the Fitbits, Apple Watches, now Garmin's and Oura Rings, getting daily measures of sleep, activity, and at a sort of sub-daily, more granular level about the sleep stages and heart rate variability and minute-to-minute changes. And then more recently with SensorKit getting a lot of constructs from the phone that again are relevant to mental health. So I'll take us through a couple of them. A lot of these factors have of a lot of these mobile measures correlate with in our study um, within people with mood. So within a given individual, when they get less activity, their mood generally is worse. And then for a subset of these, there's also a between person association that people with who exercise less have more depression. And this is again a subset of the factors we found associated. Um, for sleep duration, this is highlighting how variation in sleep is as, or in some cases, more important than the absolute level. So on the right side of the graphs, they're showing variation, and you can see total sleep time is important, but even as important is the variation. So sleeping, uh, 4 hours some nights and 8 hours other nights is considerably worse for your mood than sleeping 6 hours every night. Similarly, the going to bed earlier is associated with better mood, but the variation in that bedtime is even more important than the absolute level. Along the same
Srijan,
lines,
there's a question in the chat. I'll
oh,
read it to you. Why measure minute to minute data but only ask for mood once per day? Would EMA not work better?
great question, and yeah, we would it would work better. Yeah, I think um, but asking people their mood every minute would get incredibly burdensome and hurt compliance and also affect what they're doing. So um, I think different studies, the right balance is at different points. I know a lot of EMA studies ask, 3, 5, 7 times a day. And uh, we may do that at some point. I think for this study, or both intern and prompt, they go on for over a year. So we sort of trade, and the compliance gets lower the more we ask. So to try to maintain data over the long period of time, we only ask once a day. Um, but I think there is real value in getting more measurements throughout the day, and would love to do that if we could do it in a way that doesn't cause attrition from the study. But again, yeah, if other people that have thoughts or ideas and of getting it more often, I would love to discuss in here. Thanks for the question. Um, so the other sleep related factor that I wanted to highlight is circadian phase. So um, we can measure, and the math is complicated, but to oversimplify, our lowest heart rate usually under normal circumstances during the day is sometime overnight during our main sleep period. And ideally that matches well with the midpoint of your sleep. So, if you're sleeping midnight to 8 a.m., then at 4 a.m., and that would also be your lowest heart rate. And the more misaligned those things are, we find that for an individual, when that's misaligned, their mood is worse. And then people who have that chronically misaligned more strongly have worse PHQ scores, higher depression. So again, this is sort of a feature of this circadian phase that seems relevant to mood and depression, but we wouldn't have been able to capture, at least at this sort of scale, without mobile technology. Um, I wanted to highlight more of the sensor kit stuff because it's newer and hopefully would be of interest to you guys. So this is in the last few years uh, a type of data made available through Apple. So this is only relevant to iPhones. To get a bunch of the data streams that are captured by our phone and are relevant to mental health. So um, we rolled this out a couple of years ago in the Intern Health Study, capturing the five metrics on the x-axis, and have had relatively good compliance of people signing up for these features and sticking with it. And I'll again run through a few of them that we've found of interest. Yu Feng has done this work on geolocation. So through SensorKit, we don't get actual locations or GPS coordinates of where people are, but get information from when they're home, when they're at work, and when they're in some other non-home or work location. There's a concept in particularly strong in psychology and other social sciences about third places, um, places other than work and home, and how that's been theorized to be an important factor in well-being, and that encouraging more third places and people visiting third places is important for well-being. And through this, we're finding, I think for the first time, objective, evidence at this scale supporting that. So on the left side, we see that people who are um, not depressed spend somewhere 20-21% of their time in third places away from home and work, whereas depressed people spend a lot less time, something like 11% of their time at third places. So depressed people are spending a lot less time at third places than non-depressed people. And then again, within individuals, we see the same sort of relationship. On days where individuals are going to more third places, their mood is better, and days when they're just going to home at work, their mood is worse. So this suggests that third places are important, and we find that a portion of the relationship between third places and mood is mediated by exercise and how much light they're getting. Um, which leads me into the next sort of sensor kit feature that we've looked at. We can now measure, particularly from the watch, how much light exposure people are getting. Um, you can see this that in June and July, people are getting the most light, particularly in the middle of the day, and we find essentially that all types of light exposure, the more luxes you get exposed to, the better your mood. And we find that this is true for light across the day, not just morning. And again, suggests that this could be an important feature for mood. But I think the important part is that we can capture this now and incorporate that into different analyses. Um, Somewhat related to light and sleep, we this is sort of how sleep duration changes across the year and across geography, latitude. So in the middle of the graph in July, again, you can see that sleep is the shortest by the sort of lighter green lines across geography. But as we move into the winter months where the days are shorter, the our sleep duration increases, but increases a lot more in northern climates, in higher latitudes, where sleep duration is substantially, 30, 40 minutes longer in some cases. Whereas in closer to the equator, the sleep duration doesn't change much. But again, this seems likely related to light exposure and the length of the day, and kind of variation we can capture with mobile technology that we couldn't before. Um, Another sensor kit feature that we can capture now is typing speed, how you're typing on the phone. And you can see that when you wake up, your typing speed is relatively slow, but rapidly increases as we wake up, and then hits a peak. And the peak is seems different for different people. Um, Often at 10, 12 hours a day is we're still at a high level of typing speed and at our peak. But then it tends to decline pretty rapidly as you get into 12, 15 hours a day or from waking up. But captures sort of, in a sense, cognitive function and how that changes with fatigue and maps on closely with more active but gold standard measures of cognitive fatigue. Um, One of the other features from a sensor kit that we can measure is phone usage and different apps on our phone. We don't have data on the specific apps, but in different categories. One is there's been a lot of interest in social media and social networking apps, and we find that there's a relationship between social media use and mood, but in this sample, at least, it's a complicated relationship. So um, on days, and we see an interaction between the mood you're coming into the day with and social media use. So uh, on days where your mood is poor, before yesterday's mood was poor, then the more social media you use, the worse your mood is compared to not using it. But on days where your mood was pretty good coming in, or particularly good coming into the day, then social media use seems to increase mood. So there seems to be an interaction between prior day mood and social media use on next day mood. Um, I'll jump a little bit into the other study, Compass. Uh, so the intern study, we follow folks from when they're relatively healthy in a low stress period, um, into the high stress period of internship and depression increases. Compass is sort of the converse. Um, in this study, we recruit people who are on the wait list for mental health care at in ambulatory psychiatry, university health counseling, but largely across the university. Um, so they're coming in, at one of their worst points, and then we randomize them to a few digital treatments, uh, follow them through that period, and then at some point between 2 to 6 weeks after they enroll in the study, they get into the clinic and start their clinic-based treatments, and we follow them through that with the same tools as the intern study with wearable devices, DNA, and a lot of the same assessments on questionnaires through the app. Um, they not all of them get better, but about uh, 20-25% of them are in remission from depression with the digital treatments by the time they get to the clinic-based appointments. And then they continue to improve throughout the year with many of them going into remission and some continuing on with symptoms. So for this sample, again, we have this is um, Fitbit-based data by and large. In this sample, we find, again, relationship between sleep and activity and mood. But we find that most people in the sample have an optimal sleep duration, a sleep duration where their mood is highest, and on days where they sleep more, their mood is lower, and days they sleep less, their mood is also lower. On average, that optimal sleep duration was about was a little less than 7 hours, 6.85 hours. But we find a huge variation in that optimal number between people with a standard deviation of almost two. So for some people, the optimal sleep duration was more like 8.5 hours, but for some, it was more like 5.5 hours. And this could also be another target that people identifying what's optimal for them could help have much more personalized recommendations on sleep rather than sort of the generic recommendations that we have now of trying to just sleep between 7 to 9 hours a day. For activity, we don't find an optimal amount, but find that the relationship between steps and mood, uh, the slope of the line gets shallower as we get to higher and higher steps. Um, the one of the last things I wanted to highlight is how we're trying to not just look at mobile technology on its own, but combine with other factors, and in this case, combine with genomics. Um, in both samples, we have DNA samples from the subjects, uh, and most of the traits we're looking at, in particular depression, but other psychiatric ones as well, there's not one or two or 10 genes that are important, um, but the genomic risk is spread out very widely across the genome. Psychiatric disorders are among the most polygenic of all traits that we've looked at in genomics. So for things like traits like this, it's particularly useful to look at polygenic risk scores with some your risk of, in this case, depression across um, millions of sites across the genome give you one score. So um, we've applied that to the intern study and are doing it in Compass as well. This is showing the relationship between the polygenic risk score across the x-axis and depression. The lower line is before internship starts or during the low stress period, and there's a pretty weak relationship. It's significant, but weak between people with higher polygenic risk scores have more depression. But the relationship becomes much stronger amongst people when they're in internship. Um, you can see people with a high polygenic risk score have the highest rates of depression. People with a middle sort of polygenic risk score have lower depression, and people with a very low polygenic risk score have almost none of them are depressed. So it seems like in this case, um, the very low polygenic risk score seems to be a really strong resilience factor or predictor of depression. What we've done a lot recently is combine the that sort of polygenic risk score with mobile technologies and sort of emulated trials to get more. personalized about which factors are important for which individual. So um, this is work led by Jenny, looking at, in this case, social support. So on the x-axis is how much social support an intern loses once they start internship. Most people lose some of their social network and have poor social support. And on the left side of the graph, you see what the sort of relationship that we would have expected before the study. um, uh, People with a lighter blue line with a low polygenic risk score for depression have substantially less depression than people with a high polygenic risk score in the darker blue line. But as we move across the graph to cases where people are not losing social support and even gaining social support, we see the lines flip. So people with a high polygenic risk score for depressions in those sorts of good social situations actually have lower depression and are thriving more than people with a low polygenic risk score for depression. So in this case, it seems to be the what we thought was a polygenic risk for depression is actually just a sensitivity to the social environment. And we see slightly different but analogous situations for other factors than social support. So this is exercise or step count, and this is an emulated trial of step count, showing again what you'd expect that as we go through the quintiles and we see step count increase on the x-axis, depression and PHQ-9 scores go down. So people who exercise more have lower depression, and this suggests that there's a causal relationship, or we can make more of a causal claim because of the emulated trial. But when we split people by polygenic risk score, we see again people with low polygenic risk score with this step count feature measured through mobile technology. There's a relationship, but it's much weaker. There, people with who walk more have slightly less depressive symptoms than people who walk less. But among the people with a very high polygenic risk score for depression, the relationship is much stronger. That taking steps and walking seems to be particularly effective in reducing depression in this in the high polygenic risk score group. And the same sort of thing with sleep duration. The effect of sleep duration on depression seems again particularly high among people with a polygenic risk predisposition for depression. Um, so we've looked at a bunch of factors so far. For most, it seems like those with a high polygenic risk for depression are more sensitive to, like we've gone through the social environment, social support, physical activity, and sleep duration, um, and might be more interventions targeting these things might be more effective among the high polygenic risk group. Um, and the last thing I wanted to highlight was that we're trying to hopefully have, convince you or you see the potential in a lot of these mobile technology factors influencing behavior. What we're finding, and this is work that Meng helped lead, that different factors are important for different people. So for some folks, for about 80% of the sample, uh, more steps associates with lower mood, but for a small minority, about 15%, it's the opposite, and more steps correlate with worse mood. Sleep duration seems to be important for a lot of people, and but particularly important for some. And so we can capture what's driving mood for each individual um, in different ways. And then we've put together this mood driver system that uses LLMs to uh, pull through that data and give feedback to individuals, highlighting which mobile technology feature is most important in driving their mood and suggesting ways to target those for intervention, but hopefully giving a way for people to understand themselves better and change their lives in ways that they could target the features most important for them. Um, so I ran through a lot of different studies and papers, but hopefully gave you a sense of how we can use mobile technology to help further the sort of broader goal of preventing depression. Um, how sort of we're capturing objective real-time data that used to be only accessible through self-report. And especially with SensorKit and hopefully newer technologies coming on board, we can capture constructs that are really important to well-being and mental health. Um, I think the two features of Intern Health Study and Compass I wanted to highlight that I think are important to our work is a little bit what we referred to earlier. It's a long study. Both of these are long studies over a year. So that and plus capturing the natural experiment part, the start of internship or the start of treatment for Compass allows us to see changes over time and capture within subject effects and I think in the broader field, within subject changes are both more likely to be causal and more easier to pick up than between subjects effects and I think can be a focus for mobile technology work more broadly. And then the larger sample sizes allow us to put together the mobile technology with other um, research approaches like genomics to get more personalized about which factors are important for which individuals. Um, so thank you all for listening.